Unmute Pani. Okay, I'll start then. Thank you. Nothing else. Thank you so much. Start with the. Good morning, everybody. The class which I'll be taking today will be occipital posterior position. Okay. So before going to the topic proper, that is the occipital posterior position, so we need to understand certain definitions, which I'm sure if you have come to OBG clinicals, we have dealt with it, but still I would like to revise it again. Okay. So what are the important definitions we need to know is one is the fetal lie. What is fetal lie? It is the relationship of the long axis of the fetus to the long axis of the mother or the uterus. Okay. Presentation. So what's the presentation? The part of the fetus which enters the lower pole of the uterus first is called as the presentation. So we have different types of presentations depending on what enters first. We have cephalic presentation, breech presentation. So with respect to this topic, occipital posterior, so what is the common presentation here? Is the vertex presentation, the cephalic presentation. So presenting part is the part of the presentation which overlies the internal os. So coming to the attitude. So what is attitude? Attitude is the relationship of the fetal parts to one another. So what is the normal attitude of the fetus inside the womb of the mother? So it is the attitude of universal flexion. But when we come to this topic as to what is occipital posterior position, so the attitude of universal flexion is not maintained. So when there is a partial deflection or when there is a deflexed attitude of the fetus, then we get occipital posterior position. What's the denominator? So denominator is an arbitrary bony point on the presenting part which is taken as a landmark. So when it comes to cephalic or vertex presentation, the bony part or the denominator is the occiput. So what is the position of the fetus? How many positions of the fetus are there? That basically 6 positions of the fetus in vertex presentation. That is left occipital anterior, left occipital posterior, left occipital transverse, right occipital anterior, right occipital transverse, and right occipital posterior. So occipital posterior is the relationship of the denominator of the presenting part to the right or left of maternal axis. So that is occipital posterior here, the occiput is posterior. The position of the occiput is posterior in the pelvis. Okay. So that's about the position. So coming to the occipital posterior position proper. Okay. So what do you understand? So is it a normal position? What is the normal position? What is the commonest position? So it is the occipital anterior, right? LOA, left occipital anterior is the commonest position. Occipital posterior is not normal, so it comes as in the topic of malposition. So malposition refers to any position of the vertex other than a flexed occipital anterior one. Okay? So in a vertex presentation, where the occiput is placed posteriorly over the sacroiliac joint or directly over the sacrum, that is called as an occipital posterior position. So what are the two types of occipital posterior? We have the ROP and the LOP. So right occipital posterior means when the occiput is placed over the right sacroiliac joint, whereas LOP is when the occiput is placed over the left sacroiliac joint. Okay. So when it points towards the sacrum, then we call it as the direct occipital posterior. So all these 3 positions can be primary, that is, can be present before the onset of labor, or secondary, that is, develops after the labor starts. So what is the incidence of occipital posterior? At the onset of labor, the incidence of OP or occipital posterior is about 10% of all vertex presentation. ROP is 5 times more common than the left occipital posterior. Why is it so? No, it's mainly because of the dextral rotation of the uterus and the presence of sigmoid colon on the left, which disfavors a LOP position. So what are the causes for occipital posterior position? So the shape of the pelvic inlet. So in more than 50% of the OP position, it is associated with either an anthropoid or an android pelvis. The wide occiput can comfortably be placed in the wider posterior segment of the pelvis. So if you look at the two types of pelvis here, okay, so what do you see in the anthropoid pelvis? If you divide it, the inlet, or if you divide the space there, so you see that there is a more space available posteriorly, so thus favoring a occipital posterior. What are the fetal factors? Fetal factors which favor an occipital-posterior position are the marked deflection of the fetal head. What are the causes of deflection? It could be because of a high pelvic inclination, attachment of the placenta on the anterior wall of the uterus, primary brachycephaly. This shortens the length of the liver from the frontal to the atlanto-occipital joint, thereby diminishing the effective movement of flexion. So these are the fetal factors which favor deflection and hence occipital-posterior position. Okay. So the uterine factors. So what are the uterine factors which can lead to persistent deflection and occipital-posterior position is abnormal uterine contraction, which can either be a cause or a effect. So next comes to the most important, okay, how do we diagnose that it is an occipital-posterior position? Okay, so we do it by abdominal examination, vaginal examination. Okay, so what abdominal examination? So when you look at an abdomen, okay, in a lady who is term and is in labor or around the time of term, you see that there is subumbilical flattening. No, it's very typical when you see that the umbilicus is there and beneath the umbilicus you see a complete flattening. So then you should suspect that probably this is a OP or occipital posterior position. So when you do the umbilical grip, the fetal limbs are felt more easily near the midline, because just imagine the fetus is occipital posterior, so all the limbs are pushed more anteriorly. So the limbs are felt very easily near the midline on either side. The fetal back is felt far away from the midline on the flank and is often very difficult to outline clearly. And the anterior shoulder lies far away from the midline. So when you do the pelvic grip, most often since it is a deflexed head, so bigger diameter has to enter the inlet of the pelvis. So what is the commonest thing is engagement is delayed. So when you do a pelvic grip, you see that the head is not engaged. So how do you know that the head is engaged? One is, so there are two things here. One is a fixed head, mobile head, and an engaged head. Okay. So mobile head is when you do a pelvic grip, when you grasp the fetal head, you can easily move it. Okay. So that's a mobile head. But in some cases, the head is not mobile. That is, it has entered the pelvis, but not completely, and it's not engaged. So when the head is 2/5 palpable in your first pelvic grip, then we say that the head is engaged. So most often in occipital posterior position, the head will not be engaged, and the cephalic prominence, that is the sinciput, is not felt so prominently as in a well-flexed occipital anterior. So since it's an occipital posterior, so what happens to the heart sounds? So the maximum intensity of the fetal heart sounds is heard on the flank and is often very difficult to locate, especially in a left occipital posterior. However, in direct occipital posterior, the FHS is distinctly felt in the midline. Okay, so this picture will tell you, so in why in occipital posterior position, the limbs. So you can see in the B position is the occipital anterior, whereas A is the occipital posterior. So the limbs are felt more anteriorly and the back is posteriorly. So most often it is very difficult to localize the fetal heart sound unless it is a direct occipital posterior where you can locate the FHS directly in the midline. Whereas in LOA, left occipital anterior, where is the normally fetal heart sounds heard? It's always heard in the spino-umbilical line, the midpoint of that. Okay, wherever the back is, that side. So coming to the vaginal examination, the findings in early labor are there will be an elongated bag of membranes which is likely to rupture during examination. Okay, so the occipital posterior positions, when patients are there, they're more likely to have a pre-labor rupture of membranes. Second is the sagittal suture occupies any of the oblique diameters of the pelvis. The posterior fontanelle is felt near the sacroiliac joint, and the anterior fontanelle is more easily felt because of the deflection of the head. In late labor, the diagnosis is difficult because of the caput formation, which obliterates the sutures and the fontanelle. Okay. So in a well-flexed head, you remember the dictum, you should never be able to feel the anterior fontanelle. If you are able to feel the anterior fontanelle, that means this head is a deflexed head. So this is the most important question which people will be asked is the mechanism of labor in occipital posterior. So normally the head, in this case, the head engages in the right oblique diameter in ROP and the left oblique diameter in the LOP. Okay. So the engaging diameter is the biparietal diameter and the occipitofrontal diameter in occipital posterior. So you should know the values of these diameters. Okay. So normally, what is the transverse diameter of the head which engages in OP? Is the biparietal diameter, which is 9.5 centimeter. But the engaging anterior posterior diameter is the suboccipitofrontal or the occipitofrontal, which is 11.5 centimeters. Okay. Whereas in a well-flexed occipital anterior, it is suboccipitobregmatic, which is 9.5. So engagement occurs early in a well-flexed LOA. Whereas in a LOP or ROP, the engaging diameter is occipitofrontal diameter, which is 11.5 centimeters. Hence, engagement is delayed. Okay. So this chart represents the mechanism of labor in occipitoposterior position. Okay. So diameter of the engagement is the oblique diameter and the engaging diameter being the occipitofrontal 11.5 centimeters. There are two things which can occur. Okay, one is it's a favorable, wherein OP is a favorable in certain conditions and it is unfavorable in certain conditions. So when is occipitoposterior delivery favorable? When the uterine contractions are very good and it has the lady is having a favorable pelvis. So what is a favorable pelvis? Where the posterior segment is quite roomy. So such favorable pelvis, we have the anthropoid pelvis. Okay. So in an anthropoid pelvis, in presence of good uterine contraction, so occipitoposterior positions have a favorable outcome. So what happens is when the uterine contractions are good and the pelvis is quite roomy, as and when the lady goes into labor, though the head is deflexed, it goes on increase, the flexion goes on increasing and engagement takes place, though it is delayed. Okay. After engagement, the second step is descent with increasing flexion. Okay. And third is internal rotation. So normally in an LOA, left occipital anterior position, the internal rotation occurs by 1/8 of a circle or 45 degree. But in occipital posterior position, the internal rotation is more. Okay, it has to rotate so that it has to come directly behind the symphysis pubis. So the rotation is by 3/8 of the circle or, okay, 3/8 of the circle or 135 degrees. Okay, so by 3/8 of the circle, the rotation, long internal rotation takes place, as a result of which the occiput comes to lie directly behind the symphysis pubis. Okay, so the rest of the steps is the same: engagement, descent with increasing flexion, long internal rotation, then with increasing contractions, the head delivers by extension, and then there is restitution and external rotation. So what is the thing which, though it is favorable, what you notice is in occipitoposterior, when things are also favorable, most often the labor is prolonged. Okay, one, because engagement is delayed, and second, because it has to undergo a long internal rotation. But though the labor is prolonged, if the conditions are favorable, most often delivery takes place without any undue unfavorable circumstances. Okay, so most often the obstetric outcome is good with a healthy mother and the healthy baby. But certain times what happens is the outcome is not favorable. In which condition? One is when the uterine contractions are not good enough. Okay, and second, it's an android pelvis. Okay, and so there is a slight mistake in this presentation. You have to remove the anthropoid pelvis from the unfavorable thing. Just read it as android pelvis. Okay, so in such conditions, what happens is the engagement is delayed. Okay, so sorry, you can either in anthropoid pelvis, usually the outcome is good, but in the subsequent this I'll explain you how exactly these things takes place. So even in an unfavorable outcome, what happens is the engagement is delayed. Okay, even in favorable pelvis also engagement is delayed. But what happens is the deflection persists, okay, particularly in an anthropoid pelvis. So when the head goes and hits the pelvic floor, because there is more space posteriorly, there are three things which can occur. Okay, one is the rotation, internal rotation starts taking place. So it starts taking place either it occurs 1/8, 2/8, or 3/8. So for the normal delivery to take place, it has to take place by 3/8 of the circle, right? So that the occiput comes and lies directly behind the symphysis pubis. But sometimes, if there is mild deflection, so there is an anterior rotation of the occiput by only 1/8 of the circle, such that the occiput comes and lies laterally. Okay, that is called as a left occipitotransverse, or ROT or LOT, and it comes and goes and gets stuck over there for a long period of time, and this can result in deep transverse arrest. Okay, in certain cases what happens is there is moderate deflection. In such cases there is complete non-rotation of the occiput, so wherever the occiput is there, it stays over there. So this is called as an oblique posterior arrest. But however, if there is severe deflection, then there is posterior rotation of the occiput, so result in direct occipitosacral position. So if it is a spacious gynecoid or an anthropoid pelvis, so the delivery which occurs is the face to pubis delivery. However, if these two conditions are not there, then most often it results in arrest. Okay. So this picture, it tells us what exactly happens in a occipitoposterior position. So if it is a right, this is a right occipitoposterior position. So if it is favorable, so the rotation occurs by 3/8 of the circle, and delivery occurs as in a normal LOA. Okay, delivery by extension, and there is delivery of the rest of the body. Whereas there are three things which can occur. Okay, one is if there is mild deflection, there is a very short anterior rotation, that is 1/8 of the circle. So there is the occiput comes to lies directly in the transverse position. Okay, so this is called as this results in a deep transverse arrest. In some cases there will be non-rotation, and if it is a spacious gynecoid or an anthropoid pelvis, posterior rotation occurs such that the occiput comes to lie directly in front of this sacrum, resulting in direct occipitoposterior position, and with good uterine contractions, most often they deliver by face to pubis delivery, where the delivery occurs by flexion. Okay, whereas in LOA the head delivers by extension, whereas in face to pubis delivery the head delivers by flexion. Okay, so it's the same thing which I have explained to you. So this is again the face to pubis delivery, wherein the head delivers by a movement of flexion. Okay. So coming to the course of labor, okay, so what happens in occipitoposterior position is, in the first stage of labor, there is a tendency to delay. So engagement is delayed. So why is the engagement delayed? One is because of the persistence of deflection of the head, thereby increasing the diameter of engagement. And second, the driving force transmitted through the fetal axis is not in alignment with the axis of the inlet. Second reason being is, so whenever the head is deflexed, it becomes ovoid, and this cannot fit into the spherical lower segment, as a result of which there is loss of ball valve action during the uterine contraction, resulting in early rupture of membranes and drainage of the lycra laminae. And third important thing is because of the ill-fitting deflex head to the lower uterine segment, there is a lack of stimulus to the uterine contraction. This results in an abnormal uterine contractions with the slow dilatation of the cervix. Second stage is also delayed because of the long internal rotation or the malrotations, which sometimes the arrest of the head. This can happen in an android pelvis or in mid-pelvic contractions. If it is not recognized properly, then sometimes it can cause arrest of the head, which can lead to obstructed labor and unfavorable manifestations. Coming to the third stage of the labor, there's more chances of because of the prolonged labor, it can result in increased incidence of postpartum hemorrhage, and also when the head is delivered by a movement of flexion or because of the prolonged labor, sometimes there can be trauma to the genital tract. So coming to the mode of delivery, there is a long anterior rotation of the occiput. Spontaneous or assisted vaginal delivery usually occurs in 90% of the cases. In some cases, there is a short posterior rotation. In such cases, the delivery occurs by face to pubis, and in face to pubis, since the head comes out by flexion, okay, so there is a more chance of perineal injuries than with the anterior vertex delivery. And if there is non-rotation or short anterior rotation, usually it results in arrest. So in such cases, spontaneous vaginal delivery is unlikely except in favorable circumstances. So when left uncared for, it results in prolonged labor, obstructed labor. Vaginal operative delivery is sometimes, we may have to go for operative vaginal, putting a vacuum or a forceps delivery, and this can result in a trauma to the genital tract or trauma to the or injury to the fetal head. So what is the prognosis of occipital posterior position? So there is increased maternal morbidity, obviously, because one, labor is prolonged, so and also because of increased incidence of operative vaginal delivery or even a cesarean section. Hence the morbidity is more when compared to left occipital anterior position. And also there is increased perinatal morbidity and mortality because of asphyxia and trauma during the vaginal operative delivery. So, however, it is what we have to remember is in 4 out of 5 cases, usually there is no trouble and the fetus is delivered spontaneously. So, how do we manage labor here? So, most important is we need to diagnose early so that we are more vigilant, okay, so that she doesn't land up in an obstructed labor, okay. So the early diagnosis is the key here. We have to be strictly vigilant and have a watchful expectancy, hoping for a descent and anterior rotation of the occiput, and timely interference is needed. And sometimes early cesarean section, we have to plan if there is no progress, okay. So this is the scheme of management of occipital. Is nothing but it's just a quick review of whatever I told you till now. Coming to the key points here is occipital posterior position is an abnormal position of the vertex rather than abnormal presentation. The common causes of OP are anthropoid or an android pelvis, the deflection of the fetal head and abnormal uterine contraction. Engagement of the head is delayed because of deflection, but however, in 90% of the cases, there is a complete anterior rotation, that is by 3/8 of the circle, and the delivery occurs as an occipito-anterior. The cases may develop other abnormal positions. So depending upon the extent of rotation of the occiput, mainly 3 types of position can develop. One is an incomplete anterior rotation, wherein it can result in a DTA or a deep transverse arrest. Non-rotation can result in oblique arrest or the oblique posterior position, and malrotation, wherein there can be occipitosacral position. And if the pelvis is spacious gynecoid and anthropoid pelvis, you can have a face to pubis delivery. Okay, so labor is the expectant management is the policy, as most occipital posterior rotate anteriorly and the baby is delivered spontaneously or by instruments. The indications for intervention is whenever there is no progress, like there is an associated CPD, android pelvis, persistent deflection of the head, or a weak pelvic floor failing to guide the occiput anteriorly. Second, there is a fetal distress, as in any other case, wherein the fetal heart rate is less than 100 or more than 160 beats per minute, or there is an irregular or a meconium stain like, or sometimes when there is maternal distress wherein she is having dehydration, high tachycardia, high colored urine, or patient is highly uncooperative and emotionally unstable. In such cases, we may need to intubate. So that ends your class on occipital posterior position. Okay. So just take the attendance. ಕ್ಲೋಸ್ ಮಾಡಲಿಲ್ಲ ಕ್ಲೋಸ್ ಮಾಡಿಲ್ಲ ನಾನು ಅಷ್ಟೇ ಇಟ್ಟೆ ಕ್ಲೋಸ್ ಮಾಡಿಲ್ಲ